Sebastián, ¿te parece que podemos empezar?
Sí, perfecto, comencemos.
Bueno, excelente, buen día a todos. Gracias por acompañarnos hoy en este webinar, que es el último de la serie. Primero me presento yo soy Andrés Pichón Rivier, soy el director general del IEX, que es el Instituto de Efectividad Clínica y Sanitaria, que es la institución que organizó esta serie de webinars. Les cuento muy brevemente acerca del instituto. Nosotros somos una institución sin fines de lucro que trabaja hace 20 años en salud pública en Latinoamérica, pero también en otras regiones del mundo. Y en el instituto hacemos 3 cosas principalmente. La primera es investigación en distintas áreas de salud pública. La otra es cooperación técnica con gobiernos y con sistemas de salud. Y la otra, que es muy importante para nosotros, es la educación y la capacitación. Este webinar se integra sobre todo en esta última área de capacitación. Quizás algunos de ustedes nos vienen siguiendo ya desde el principio de año con esta actividad, pero les cuento brevemente que esto es una actividad educativa que la hicimos con el apoyo de Pfizer, que nos dio un subsidio independiente. Quiere decir que nosotros tuvimos total libertad para el diseño del programa y de las actividades, pero agradecemos mucho a Pfizer la confianza que tuvo en nosotros para apoyarnos en esta actividad y también para permitir hacer una actividad en Real World Evidence, que creemos que es una deuda que tiene la región. También quiero agradecer al Fondo Nacional de Recursos de Uruguay, al CONITEC de Argentina y a IETS de Colombia, que son instituciones que nos ayudaron en el diseño del programa, identificación de los participantes y en otras actividades. Y, como quizás también saben, este es el último webinar de una serie que comenzó a principios de año y que incluyó una serie de actividades, entre otras un curso introductorio sobre Real World Evidence, un curso avanzado, y también una serie de becas para algunos proyectos de investigación en la región, donde nosotros les otorgamos algunos fondos muy menores, lamentablemente, pero unos fondos para algunos gastos, pero sobre todo dándoles tutoría para poder llevarlos adelante. Y en lo que esperamos también que sea una de las primeras actividades en Real World Evidence y poder continuarlo el año que viene, porque también hubo mucha demanda. Nosotros no pudimos aceptar a toda la gente que se quiso inscribir, tuvimos muchos más postulantes que vacantes, pero muchísimos más, no mucho más, muchísimos más, de todos los países de la región. Así que está claro que esta es una demanda muy importante y esperamos poder acompañarla también el año próximo y de ahora más con otras actividades. Así que es solo para darles la bienvenida. Ahora lo voy a dejar a Sebastián, que fue Sebastián García Martínez, quien coordinó todo este programa a lo largo del año. Así que los dejo con Sebastián para que les cuente un poco específicamente de qué se trata la actividad de hoy. Bienvenidos y muchas gracias otra vez.
Bueno, ¿qué tal? ¿Cómo están? Bueno, un placer, la verdad, compartir este webinar, tanto con Débora, Vania, Julián y Karen. Muchísimas gracias por estar acá. Bueno, en este último webinar del año, como decía Andrés, vamos a conversar sobre el rol de los distintos actores y la visión de los distintos actores desde el punto de vista para la incorporación de Real World Evidence. En este webinar va a estar Karen Facey de la Universidad de Edimburgo y a su vez forma parte de la iniciativa RWE Decisions, ¿sí? Que es una iniciativa europea orientada a mejorar la utilización de Real World Evidence. Por otro lado, también nos acompaña Débora Aligieri, que forma parte de la Asociación de Diabetes Brasilera, que va a dar la visión desde el punto de vista de los pacientes. Vania Canuto, que es la directora de CONITEC, en el Ministerio de Salud de Brasil, que va a hablar de la posición desde una agencia de evaluación de tecnologías sanitarias. Julián Guilherme, que forma parte de Pfizer y es el líder para Real World Evidence para Latinoamérica, y va a hablar desde el punto de vista de los productores. Por lo tanto, nuevamente vuelvo a decir que agradezco mucho la participación de ustedes y es un placer compartir este último webinar con ustedes. Va a comenzar la presentación Karen, después va a seguir Débora, después Vania, después Julián, y dejamos las preguntas para el final. Karen, muchísimas gracias.
That's great. Apologies for that technical glitch, but thank you very much for involving me in this session this afternoon, because it's a great honor. I hear how well this course has been going, and I'm delighted to be able to bring perhaps a view from what's happening not just in Europe, but Canada has been involved in our work as well. So I am a visiting research fellow at the University of Edinburgh, but I've been working just a couple of days a month with a multi-stakeholder initiative, which has been led by healthcare payers in Europe. And they got together about 5 or 6 years ago when they could see particularly cell and gene therapies coming over the horizon, which were very high cost, but with very limited clinical data, often because of accelerated regulatory approval. So they were saying, we've heard about digital advancements in our systems. Can we come together to discuss whether we can use the data we have in our health systems to build robust enough real-world evidence, RWE, either to help health technology developers in clinical development, or particularly for conditional reimbursement processes, where we have an interim reimbursement with additional data collection. And thinking in Europe, where we have very different sized countries, from small countries like where I live in Scotland of 3 or 5 million people, up to the larger countries of 50 million. Can we work together? Can we align our data collection requirements? And what's everybody's role in this? You know, the payers were saying, we're interested in what's happening, but we don't know how to move forward. So we brought together all stakeholders to discuss some of the big issues, and we identified 2 key principles for working together, and that is transparency and collaboration. And collaboration being key, we recognize that actually each stakeholder has to take responsibilities for the aspects they can influence and work collaboratively together. And I work particularly in the area of rare diseases, and this is essential here where we have a small number of patients. So we see real-world evidence generation as a shared responsibility, and we need to be clear about who does what and who pays for what. And we recommend iterative dialogues or scientific advice among stakeholders with technology developers to discuss what clinical evidence they might have, but what real-world evidence may be available from a particular jurisdiction or from other jurisdictions or international sources such as. So what we then did, working across all the stakeholders, we generated a list of actions that each stakeholder group could take. And I'm just going to present a couple of them here. If you go to the paper, you can see all the actions in detail. And for those on the course, I went into this into more detail. But say, for example, national payers and HTA bodies have a role to play at the policy level to encourage establishment of national processes for data collection which suit their needs. They need to inform national decision makers about the need for real-world data and the importance it can have to optimize use of treatments. We need to work with industry to understand what real-world data they can collect. We need to think about financing. And then at an individual level, looking at a particular health technology assessment for an individual medicine, we need to perhaps explore transferability of data. For example, in South America, could data be taken from Brazil and used in Argentina? What would the transferability issues be? We need to think about how we make data collection as robust as possible, encouraging use of protocols for data collection, sharing our data collection post-reimbursement with what's happening in other countries. And there's a lot of interest in what we call outcome-based managed entry agreements or risk-sharing agreements, and questions about how we can make those better by having more purposeful data collection and publishing our data collection protocols. I know that this is sponsored by Pfizer, so I thought I'd put up the actions for pharmaceutical industry. We would like more transparency from industry, so to publish data collection protocols, statistical analysis plans, tell us how you've made certain decisions about the way you curate real-world data so that we can assess fitness for purpose and assess the methodological issues that arise, but work together on some of those challenges, because we know that real-world data will never be as good as clinical trial data. So how can we overcome some of the challenges that arise? And we recommend that industry engages in multi-company collaborations. And I just wanted to share with you briefly work which was published just 2 weeks ago, which has come out of the Real World Evidence for Decisions initiatives, which shows how industry can work together. So industry had done a systematic review that looked at how EU, HTA and payers viewed real-world data, and a range of papers are shown here, and they identified that real-world data is already used in HTA for the range of purposes shown here. So we know for epidemiology, number of patients, but for costs, a lot in economic modeling, for natural history, for resource use, particularly for the comparator. But the papers showed quite clearly that there was still a concern about use of real-world data to demonstrate treatment effectiveness as the key evidence. And we see that this is more being used now, particularly where we see single-arm trials for the cell and gene therapies in particular, but also for some cancer therapies, and an external control arm is used. And so they looked systematically through the papers, identified that there were the same issues in the US, and we came up with 4 pillars to build real-world evidence. That's good data availability, governance, and quality. And the HTA body said that this was their key issue when reviewing real-world evidence from industry. And related to this was also methodology. How are we overcoming selection bias, which is key in real-world evidence? Then we need to build trust through transparency and demonstrating reproducibility. And we need to do this through consideration of good national policies and across country policies, and through partnership. So just to say, in this paper, what we also did was not just look at those pillars, but identify whether there was guidance out there that could help us with these issues. And over our meetings this year, we've been exploring the guidance for each of these pillars, particularly focusing on data quality. And here's an example of just a couple of guidances that are available. AHRQ in the US provides very good information about how to use clinical registries for comparative effectiveness. And in Germany, we have some. But more recently, last year, the French authority gave very good guidance, and in England, just recently, NICE produced their real-world evidence framework, and I know you've been working in collaboration with NICE. But even just in the last 2 weeks, Canada has issued a consultation on its real-world evidence framework. So a lot of HTA bodies are now producing clear guidance, and some are setting up their own data collection systems post-launch. So in Spain, I really recommend you look at these, and of course they're all in Spanish. You can now find the data collection protocols for a wide range of highly innovative technologies, and also the interim reports arising from this data collection. And these are really resulting in changes in treatment care. We've been trying to capture what's happening in different countries in terms of data sources. These are available on our website. And if anybody in South America would like to summarize what data sources you have or don't have, I know you have challenges, we'd be pleased to work with you on that. So I know I'm running out of time, so I'm just going to say that I think that real-world data collection over the life cycle of a technology is key, and all stakeholders, including regulators, need to be involved in that. Thank you very much.
Thank you very much, Karen. We will do the question and answers at the end of all the presentations. Vamos a hacer las preguntas y las respuestas a...
We are going to leave the questions and answers for the end of the presentations. Thank you, Karen. And let's move on to the next speaker. Now, Débora. Débora? Hi. Good morning. Thank you. I want to thank the IX, Sebastian, and everybody for the invitation. It is a pleasure to be here with you today. I'm going to share my screen. Thank you. I'm going to present then the topic of real-world evidence from the point of view of patients, bringing two simple ideas to the panel: the use of data and real-world evidence to improve care and social involvement or engagement. But before that, let me introduce data of my life so that you know a little bit about me, and so that you see whether there are conflicts of interest or not. I am a DM1 patient. I have a blog called Diabetes and Democracy, where I discuss social involvement in health. I'm a lawyer and I have a master's in public health care. And my thoughts result from my experience. Some 10 years ago, we started to discuss in Brazil the incorporation of insulin analogs for the treatment of diabetes, to treat diabetic patients. And when we looked at the different trials, we saw that the benefits and the results that we had in our life were not reflected in the scientific studies. Why was it that the benefits that we experienced in our lives were not reflected in the scientific studies? And how to convey what we see in our real life to the real processes in Brazil? And one thing we saw is that what we considered as relevant, the studies and the analysis of the CONITEC, was HbA1c, which was the gold pattern for the treatment of diabetes. But for us, patients who have to coexist with diabetes, with the disease, what is much more relevant is hypoglycemia, because this really affects our daily life. And therefore, as a result of public consultation from the CONITEC, we shared our experiences with hypoglycemia. And in the next analysis, hypoglycemia was considered as a relevant result by the agency. And in 2017, we incorporated the rapid action insulin analog, considering hypoglycemia as a relevant result. And the studies showed also better results. Therefore, the real-world data in this case were considered relevant results for us. And sometimes studying diabetes and analyzing what we share in the social networks, in the internet, I verified that there are a lot of things that in clinical trials are not considered or go unnoticed, or nobody approaches them, like different demands having to do with healthcare. So internet is a source of real-world data. But in order to analyze this real-world data, we need good methodologies to guarantee the quality of the trials and training for qualitative analysis. Training is key for qualitative analysis, data analysis of the systems, official data, and also internet data analysis. And it is also necessary to have interoperability amongst real-world data systems. And there is another issue that has to do with access to data and to systems, because when we speak about internet, we are speaking about private networks. Some time ago, Facebook accessed to the access to text extraction, and they have to pay now. So it's necessary to develop participative methodologies for the patients to participate in the process of data analysis to help towards the search of results. And there are different models like participatory investigation based on the community of Nina Wallerstein, based on the methodology of Pablo Freire. And the focus is not to search for somebody, but with somebody, to search with the patients. So I'm very happy to know that in Argentina, that's what you do. And you talk with the patients in order to define what is relevant. So these are the experiences done in Sao Paulo. In Sao Paulo, we have a commission of diseases and rare diseases in the Municipal Council of Healthcare. This commission or council participates in the management of healthcare policies with the mayor, and they started from the very beginning to describe a local policy for rare diseases, and they developed little by little all this until this became a law which has been passed. They held dialogues with the government, with the patients of the municipal commission, etc. In Brasilia, the University of Brasilia, there is a professor that has a group of activists like myself that have a disease like myself and that do research on public policies. And in England, there was a case of the insulin pump for diabetic people type 1 to verify the results and to verify how to take care of patients with artificial pancreas. Opportunities then for the use of real-world data, real-world evidence, a very good opportunity to define problems related to research with the patients. Another thing would be a sort of change of logic, thinking about the costs, because we have the case of incorporation of insulin analogs of long action that we've incorporated in 2019. But so far, we haven't been able to offer them in the system because of a cost issue or a price issue. And the price is a sort of limitation. And that's something very important. The cost. The cost should be considered with the use of technology like the artificial pancreas and not a limitation before the incorporation of new technology. Another thing which is important is that it is possible to discuss biases. There is somebody in Brazil, an author, that says that all researches are biased. We need to not avoid biases, but discuss them. And finally, and something I think that Karen already mentioned, we need to act together, patients, the academics, the academy, the industry, and the government throughout the process of health technology assessment and decision-making. And this is my personal contact, personal information. Once again, thank you for the invitation. And I'm sorry if I was not able to explain things correctly, but I hope I was. Thank you. Thank you very much, Débora. We understood perfectly well. It was okay. And please, Vania, now we go to your presentation. Just a clarification before Vania starts with the presentation. Any question you wish to ask, you can write it on the chat, in the chat box. We may solve some questions at the end of the presentations. Thank you, Vania. We listen to you now. Thank you. Hello. Good afternoon. It's a pleasure to be here with you today on the day of the Brazilian participation in the World Cup. We are going to talk about the experience of the CONITEC, which is not an HTA agency, but rather a commission in Brazil that already uses real-world data in their work. So the CONITEC is an organization that was created in the year 2011 in Brazil, which is responsible for assessing incorporation and inclusion of healthcare technology and create guidelines. Therefore, the CONITEC makes recommendations to the Ministry of Healthcare that is responsible for incorporating all this in Brazil. From the creation of the CONITEC, we've assessed more than 1,000 requests for the incorporation of technology. We have covered more than 170 clinical guidelines. How do we use the RWE? We use the process of technology assessment, or HTA, for the incorporation of RWE. We've used the monitoring of technologies already incorporated, and also there is another initiative, which is risk sharing. Now in HTA, for incorporating technologies in the healthcare system, Vania, I don't know if you are passing the slides because we cannot see the presentation. Yes, I'm passing the slides. They're not moving. No, they are not moving. They got frozen. It got frozen on the first one when you open the PowerPoint. You can simply start again and it might work. Can you see it now? Yes, we can now. Do you want to try to move on to the next slide? Yes. It got a little bit large now. Okay. Okay, now. Can you try moving on to the next one? So we use real-world evidence in HTA and monitoring of incorporated technologies according to the shared risk. In the area of health technology assessment, we use real-world data in order to characterize diseases or health conditions, the prevalence, the incidence in Brazil. We also use that to supplement information from the clinical studies or trials, from the randomized controlled trials, because we need to have clinical trials for evidence, but we supplement information for effectiveness and comparative safety of these technologies that are being assessed by the CONITEC, and to assess forgotten diseases or off-label use. Can you see the presentation now? Yes, we can see, yes. Not in presentation mode, but no problem. Okay, we can read and we can see. So after the incorporation of technologies, what we do is use RWE to monitor the incorporated technologies, updating the scientific evidence for safety, and later on, we may perform the health technology assessment. We observe the health-related costs and the use of resources. We use as well for the identification of the variability of clinical practice guidelines and to assess randomized control studies in our population. We use that to assess the impact of interventions in the rendering of medical services. Another action, which is more recent, that we are trying to implement now, on shared risk of the CONITEC. For example, we assess technology for rare diseases, and we recommend the incorporation through agreements of shared risk. The use of real-world evidence to construct recommendations of agreements of shared risk is very important to define outcomes and measurement methodologies. Requesting studies from real life with data of the patient in healthcare systems as of uncertainties identified upon the moment of incorporation and assessment of collected results in the agreements within the context of our healthcare system. Some other actions that we are implementing in Brazil, this one is related to interferon beta for multiple sclerosis. We published this as of RWE, observational studies performed by the Ministry of Healthcare. We used data of comparative effectiveness, and interferon beta was less effective. That was the result. Another action is a trial with 21 rare diseases in the unique healthcare system in Brazil, or SUS. This is an observational prospective study. We want to know the effectiveness of compliance of patients to the guidelines in Brazil. Another activity is a study of Zolgensma. We are going to assess the effectiveness of Zolgensma in real life. It is an observational study in an open cohort. And another action was the incorporation of Paxlovid for COVID, monitoring the results of real life and assessing the incorporation of it after a year of implementation. Another action being performed with the companies, we started with rare disease companies in order to design a study with these companies for the treatment of two diseases, MPSs. So the company is going to include the first patients in the trial in the year 2022. Another action that we have in our electronic site are reports published with data of follow-up of incorporated technologies, study of technologies with the use of administrative data. In our site of the CONITEC, you can see these reports where we assess the time for implementation, the data of utilization of technology, and the comparison between the budgetary impact. And the next steps to take are the creation in the CONITEC of a technical subcommittee that is going to assess the technologies incorporated and is going to monitor as well the agreements of shared risk. We want to publish this year the new guide of the CONITEC that will mention this new subcommittee. We have a new regulation of the CONITEC now, and it is possible through it to incorporate technology in a temporary mode. The possibility of incorporating provisionally in the law we are changing the request for technology incorporation for companies to be able to request monitoring of technologies, and we are going to hire a methodological we are going to incorporate a guide on real-world evidence. We are going to try to implement real-world evidence more. And I'm sorry for the slides that haven't worked very well, but I'm available to you if you want to ask questions. Thank you. Thank you, Vania. And now, Julian, don't worry, because we could see the screen and it was okay. Julian, would you like to start with your presentation? Thank you. Hi, good afternoon, everybody. Can you hear me? Yes? Yes. Okay, we can hear you and we can see the slides. No problem. Thank you very much for the invitation. And thank you for inviting me. I'm Guilherme Julián. As Sebastian said, I'm in charge of evidence generation, real-world evidence for Latin America and for the country. My idea is to speak quickly about how we can use the real-world data and the different stakeholders' point of view, the payers, the providers, and some examples have been given by Vania already. It may be from cost assessment point of view in order to be clearer about data, or also for prospective monitoring after incorporation of methodology for agreements of shared risk. So the idea today is to focus on the point of view of payers. Before I begin, I like to do a sort of, I like to give you an idea. We have a lot of data sources available with different advantages and disadvantages, different strong points and weak points. But if we go to the national databases, the broader databases with more coverage of the population, like ETESA in Brazil, we have a lot of studies there. We have CISPRO in Colombia, and we have some others in Mexico or in Chile. We may have a national vision that that might not give us clinical depth. When we choose our data source or database, we need to consider this balance and think about what for and how are we going to use this information or clinical information. Or maybe we can think about administrative data or reimbursement data. I'm going to focus on administrative data and data of data source or data source. And I believe that no doubt this may be a very important point when we think about health technology assessments, because sometimes the databases or the data systems are structured already, they do exist. So this may be an advantage if we are going to think about the different realities of the different countries of Latin America. Some of them may have already some ready systems of information that may support the data generation process and the RWE process in the health technology assessment process. We may use the data of real world in different ways. From the point of view of payers, we have a lot through the life cycle of the product for the launching of any technology, for example. When we think about HTA, we may find more clarity in the amount of patients eligible, because sometimes we only have epidemiological data of countries like Europe or other realities, and this may have a strong impact. The size of the population may have a strong impact on the budget. And then the understanding of the outcome of these technologies in local realities is very important. Some good examples in Brazil that Vania mentioned. We will have some results in years, and this is a very interesting opportunity in order to see this in our daily practice in Brazil. I'm going to talk about a specific example for ATTR-CM, which is a rare disease in Brazil. It is a rare disease, but the example will be applied to Brazil here. This is a cardiomyopathy. I always forget what it is, but it's a cardiomyopathy. It's an amyloidosis. It's a transthyretin amyloid cardiomyopathy. We performed this trial with DataSA's data, which is outpatient database and hospitalization database from the DataSA's point of view in Brazil. And we've identified patients with this disease. Some patients were referenced and some others were patients that might be patients with the disease. And we did this in order to be clearer about the figures of patients to be included, for example, in a budgetary action. For this, we use data from the year 2015 to the year 2021. The endpoints were the demographic characteristics, identification of the population, ATT-CRM-like, and the use of resources of the patients, the reference, and the ATTR-CM patients proper. Therefore, for this, we covered some stages. The first was the definition of disease codes, ICD codes, and procedure codes that were important for the definition of the inclusion and exclusion criteria of the patients. At the beginning, we did this as if it was a simple eligibility criteria with a lot of variables for an observational study. But then we added, or we studied some machine learning examples and applied them to detect the patients that could be potential patients. Then the variables of the disease, we would have the wild type and the hereditary ATTR-CM. We had different profiles, but we found important amount of patients in the wild type area. we found some patients that could be additional patients eligible for the technology that was created later at the CONITEC. We studied the geographical characteristics or demographic factors, and also the clinical profiles or the main codes of related disease for the patients in order to have an idea of medical education, to have a better diagnosis if possible, and the use of resources for the patients, the reference and like cohorts. All this is available to the public. It was published this week in MedGrids, and I invite you to read about it in MedGrids. And last, the study brings clarity that probably exists in patients that were not diagnosed with the disease. And this may be an important starting point, not only for medical education and better diagnosis, but to be clearer about the eligible population for that technology. And of course, this is an example, but there are other examples, as Vania mentioned, and Débora as well, of use of the real world evidence. This is interesting because we use real world and machine learning methodologies in order to be clearer about the population size, population eligible for that technology. With that, I thank you for your attention and I close this presentation. Thank you, Sebastián, over to you. Thank you. Thank you, Julian, for the presentation. I want to repeat that it's a pleasure to share this panel with you. Amongst the questions, some of them we've already answered, and there are some questions of Carlos that asks about the methodology of the real-world evidence studies or trials, and I have some questions as well. If you want, we can start with the questions of Carlos, who comments or asks about the role of real-world evidence trials regarding clinical trials, if they should be assessed through methodological instruments that are special or anything, and what's the use of real-world evidence in orphan diseases or rare diseases? I will divide the question and I will start by the last one for Karen. Basically, what's your opinion vis-a-vis the real-world evidence trials and orphan diseases, Karen?
Thank you. That's a great question. My personal view is that there's more need for real-world evidence in the area of rare diseases, because we know that we have not only small populations, but often we have clinical heterogeneity, so different presentation of disease, and we don't know a lot about the disease. So particularly for economic modeling, we need good clinical registries to establish natural history. So here's where I think links with clinicians become important, to make sure that registries are collecting the data that we might need to demonstrate the value of new treatments and to understand how patients progress through. In terms of assessment, I think that what we're all recognizing is actually critical assessment of a real-world evidence study is more difficult than that of a randomized controlled trial. We have decades of history from evidence-based medicine of how to evaluate randomized controlled trials, meta-analyses. Actually, real-world evidence studies are more challenging because we have to understand where the data have come from, what decisions we've made. So when we're looking retrospectively, for example, what are time windows? How have we curated that data and managed it and pulled it in? How do we deal with the missing data? And so there's need for adjustments. There's need for more sensitivity analyses to look at different decisions. And I think that that's what a number of the new HTA body guidances are looking at, trying to support this analysis. And it's great to hear the work at CONITEC. I think that's absolutely phenomenal. But I noted that CONITEC were talking about bringing in experts as well. And I think we need to engage with the analytical experts, because for many of us, working with the detail of this messy data isn't our expertise, but it's something we all need to upskill on.
Gracias, Karen.
Thank you, Karen. Thank you. Another component of the question was the assessment, whether the critical assessment of real-world evidence needs to be done in a different way, as Karen was saying. And Vania, I wanted to ask you whether in the submission to the CONITEC of a technology, have you included a study that may be framed in the context of real-world evidence? Do you use a particular methodology for assessment, or how do you work with this study or trial? Yes, we use real-world data as an additional evidence. For us, it is important to have sound data of efficacy, but we use these studies or trials in order to gather more information. As I said before, we are going to develop now a methodological guide in order to use this data better, because we perceived a very wide variation in data, and we need to harmonize these assessments so that the CONITEC in decision-making feels safer to use this information. I believe that we still have doubts about the data, biases, etc. So we are trying to move forward and to learn. We accept the data. We have nothing which is structured for the assessment, and this is a challenge to create a methodological guidance for real-world evidence and another guidance for the assessment of these rare diseases, because like Karen said, we have problems in assessing these orphan diseases because clinical trials in general are not controlled. They use historical cohorts, so we need to be more flexible in the assessments and use real-world data more, mainly for these type of diseases, because I believe that in some cases we cannot use the traditional methods of technology assessment for these type of diseases. And this is a big challenge for us in the CONITEC now. Julian of Pfizer, who is here with us today, knows a lot about this, and so does Débora. Thank you, Vania. Yes, Débora wanted to make a comment on the relationship between the real-world evidence studies and clinical trials. It's one, so we can stay until 10 past 1. I want to ask questions, so Débora, just a short comment on RWE and clinical trials. Thank you very much, Sebastián. Well, continuing with what Vania said, I believe a change is necessary in the model on how to perform research. And something I want to say, the issue between real-world data use and clinical trials. For us, patients, with the use of real-world data, we have the possibility of being subject of research and not objects of research, as happens with the clinical trials. We participate little, like the methodologies for the search of real-world data in systems, not in systems like the ones that Julian showed us, but if there is a dialogue or another way of doing this search, we may intervene a little bit more. And I think that that is important in order to look at the relevant outcome for the patients. Thank you. Great. I have three questions, one for Karen, another one for Débora, and another one for Julian. First, Karen, knowing the reality of Latin America vis-a-vis real-world evidence use, or RWE, same as in the rest of the world, real-world evidence is growing. But in Europe and in the United States or Canada, they have made progress in data governance compared to Latin America. From your point of view, what would you suggest us to implement as first actions towards the incorporation of real-world evidence in Latin America?
I think the key thing for me is transparency and alignment. So what we see in Europe is that no member state, no country knows what anybody else is doing. And even though we now have legislation across the 27 countries within the EU about governance and what we call the General Data Protection Regulation about how a citizen's data can be used, it's interpreted differently. So legislation to protect the privacy of a person's data and their appropriate use for primary purposes to make sure the person is treated optimally and their data is shared between health systems, primary acute care. That's the first thing. But then governance to ensure secondary use for purposes of research to optimize treatment is important, and then interpretation. So you need legislation for that, but you then need to keep talking about how you're interpreting that legislation to build trust with people like Débora and involve people like Débora. So co-creation is a word that's coming through very strongly as we have all of these discussions. But also then this alignment to recognize that if Scotland is going and collecting data and Norway is collecting data and France is collecting data and every country is doing their own thing, that's a waste. How can we align our data collection, define a minimum data set? We're all working on onasemnogene. So Vania mentioned this. I'm working with Canada at the moment, and we're doing a survey about what is the data that we are all collecting. If we could pool all that data together, yes, there will be national differences, but there will be things that are transferable. So good governance that engages with individuals, keep talking about how we interpret the governance issues to ensure confidentiality, but encourage research, and then openness about the data we're collecting.
Thanks, Karen. Muchas gracias.
Thanks, Karen. And now, vis-a-vis this, and just a question here, regarding how we can rely on data or data reliability. I wanted to ask you, Julian, what is your opinion regarding reliability of data from the point of view of whether a technology producer presents a study or a trial, how reliable data contained therein are? Thank you, Sebastian. I believe that transparency is key for us to have reliability. That's important on the data presented. So I believe that having reproducibility of the scientific methodology is very important, and being very clear in data submission. I believe that the most important aspect, all the trials have their own types of biases. So we need to be clear up front about this. We need to know that this was done with US data, that we need some clinical data like ADC that we don't have. But we believe that this is a reliable indicator of a procedure, a reliable indicator of the disease activity. So we need to have clear definitions. That's very important. And also in data submission, we need to know the methodology, and we need to be clear about the advantages and disadvantages and the limitations of the trials up front, because whether they are clinical trials of 20,000 patients or a study of real-world evidence of 30 persons with rare diseases, they all have their limitations. So we need to work with that in a clear way, because there we have to understand the risk of the data that we are using. And publication, sometimes we don't have the timing, but we need to have a clearer methodology, scientific reproducibility, I mean. Thank you, Julian. Just a question for Débora. The real-world evidence studies facilitate access to some information which is not easy to access through a clinical trial, and on occasions they accelerate the generation of information, but also they have more uncertainties because of their designs. From the point of view of a patient, we might say, well, I feel benefited because the information is generated fast, but the level of uncertainty is higher. So what's the position of the patient from the patient point of view regarding more information, faster information, but more uncertainty as well? I believe this is something that we work on from the social networks, how to do research, qualitative research, and guarantee the quality of the study or trial. I believe it's necessary. What I was saying before, I suggest a change in methodology. I suggest adapting the methodology, because one thing is to do a qualitative research about the lifestyles, for example, and something different to analyze the effectiveness or the efficacy of a technology. I believe that it's necessary to sort of adapt things. And I think that from the very beginning, when I started to understand better about medicine, evidence-based medicine, I thought it was a process with a lot of flaws because I was not, or I didn't feel reflected in the trials. So I think it's necessary now to consider that since there are limitations in evidence-based medicine, we have to consider the limitations in qualitative studies and in others. So I believe that we need to see Vania, Karen, Julian, we have to look into different changes or exchanges of experiences in different countries, like what we do in the Latin American Forum. This is a very important opportunity to guarantee improvement of uncertainty. And evidence-based medicine for us is quite more uncertain than what we consider it. It's uncertain to us, let alone what it means to you as a patient. I believe that we need to close now. I want to thank all the speakers for their participation, and I believe, in my personal opinion, talking amongst the different players or stakeholders and assuming the limitations of the real world evidence trials and non-real world evidence as well, and being able to assess them and then define coverage policies together and talk about the fact that sometimes we feel uncertainties over the decisions made and making decisions based on this level of uncertainty. I think that all this is an important point. Karen, would you like to make a closing comment? Débora, Julian, anybody? Yes, I want to thank you and congratulate you for this panel with all these different points of view. Thank you. Thank you, Julian.
I just want to say real world evidence for decisions goes beyond the EU. We've stretched into Canada. We'd love to stretch into South America, and it would be great to make contacts. You know, I could work with you on those national health database questionnaires just to show what data you've got, where the limitations are, and things aren't as rosy in the EU as they always seem. And we can learn a lot from what you're doing in South America, and it would be great to do that.
Muchísimas gracias, Karen. Seguramente estaremos en contacto.
Thank you, Karen. We will continue in touch. Thank you very much. Thank you. I also wanted to tell you that this is a very important area for all the agencies, for all the people. We have to assign importance to real-world data use because they are going to be essential for the assessment of technology. Since there are many technologies in the pipeline that are coming to the different countries with earlier efficacy or faster efficacy, it is essential for decision-making. Thank you. Thank you, Vania. I want to say once again, thank you. Thank you. I've learned a lot today. I always do. And I believe that the use of real-world evidence for us patients is an important step to change the position in our process. And we will continue discussing other things like internet use or artificial intelligence trials. This is a very wide field to explore, and it may bring some other things for analysis for real-world data. Thank you once again. Thank you all once again. Thank you. Thank you. I want to thank the rest of the attendees. And just that, let's keep in touch and we will communicate. Thank you. Thank you. Bye-bye. Bye-bye.